beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 91. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Good evening.
Good evening. How's things in India with the COVID now?
We are pretty comfortable at this point of time. There are very few cases. Some patients who got sick early during the third wave are still lurking around in our ICUs. But apart from them, we are pretty much comfortable.
Yeah, I guess most parts of the world now, we are getting some relief from COVID-19. And I guess the lockdowns are now open. So hopefully things stay as is now. And hopefully we won't get any fifth wave or sixth wave with new variant. So fingers crossed. Now, the study that we're going to discuss today is published in JAMA. And it's really interesting because we all have seen patients in intensive care unit with COVID-19 in last 2 years. And we have faced different challenges with COVID-19 pandemic, with increasing ICU admissions, increasing requirement for resources, and also dealt with the different challenges which COVID-19 presented to ICU in terms of resource capacity. Having said that, we really didn't have much idea about what happens to these patients when they leave ICU, especially the post-ICU symptoms, which are quite well known in this kind of subgroup of patients where they suffer from different challenges like fatigue, decreased exercise tolerance, lack of smell sensations. And I guess the post-ICU symptoms generally can be divided into physical, mental, and cognitive domain. And potentially those symptoms can be associated with increased one-year mortality, increased healthcare costs, and obviously lower quality of life. Having said that, the robust data around these findings was not available, and a lot of people were unsure about what's the real impact of COVID-19 on these patients down the lane after 1 year. Now, when you look at some of the data from the non-COVID patients in the past, especially with the ARDS, we know that the mortality with ARDS after 1 year is significantly higher. And also the patients who suffer from ARDS and need intensive care admission, they have significant morbidity at the end of 1 year. Similarly, in terms of non-ARDS patients, there is again enough data to suggest that ICU treatment itself involves a significant impact on lifestyle of the patients down the lane, and patients do suffer from different physical, mental, and cognitive symptoms after 1 year of intensive care stay. Having said that, with regards to COVID-19, there were only few small studies were available, which suggested there is some signal that these patients do have symptoms which can actually impair their quality of life at the end of 6 months. So this is probably the first study that is recently published in JAMA from Netherlands, called as clinical outcomes amongst patients with 1 year survival following intensive care unit treatment for COVID-19. So, Dr. Checo, can you please walk us through the methodology and the results of the trial, please?
Yeah, the Monitor IC study is a multi-center prospective control cohort study carried out in 4 Dutch hospitals. Patients were included. In fact, this is a larger study that was meant to look at outcomes among patients who were admitted to ICU, and they included patients between July of 2016 and July of 2021, or a 5-year period. And the aim of this study was to evaluate 5-year patient outcomes after ICU and identify predictors for post-ICU syndrome, as they call it. So the study that we are discussing today is a prospective cohort study, which is part of the Monitor IC study on ICU survivors, specifically during the first wave of COVID that occurred in the Netherlands. And they studied patients during the period between March 1st, 2020 and July 1st, 2020. So these patients who were admitted with COVID-19 related problems to their ICUs were the patients who were included in this study. They excluded patients who required ICU admission for less than 12 hours, who had a life expectancy of less than 48 hours, and those who were only focused for palliative care were also excluded from the trial. So they screened 452 patients with COVID-19 during the second wave in Netherlands, who were discharged alive from hospital between March 1st, 2020 and July 1st, 2020. These 452 patients were screened for eligibility, out of which they excluded 150 patients. 302 patients were included in the study. They lost a few patients to follow up. Information could not be gathered from several other patients, and the final number was 246 patients who had a complete follow-up for a 1-year period after admission to the ICU. How did they assess the outcomes? Outcomes were self-reported or reported by proxy, either online or on paper. Evaluation was carried out on the domains of physical, mental, and cognitive function. And as I mentioned, patients were followed up for a period of 1 year. The authors used several robust, mostly objective tools to evaluate the physical, mental, and cognitive symptoms and ability to return to work. Physical symptoms were assessed using the frailty score on a score of 1 to 9. They also used the checklist individual strength fatigue subscale, which is a 7-point scale. And they also evaluated patients for 30 physical problems rated on a 4-point Likert scale. Mental symptoms were similarly assessed using the Hospital Anxiety and Depression Scale for anxiety and depression, and another tool called the Impact of Event Scale 6 on a 5-point scale. Cognitive symptoms were assessed using the abbreviated Cognitive Failure Questionnaire, and they also looked at the ability to work, which ranged from full recovery and working as before to incapacity, leading to complete cessation of work over the period of 1 year. So what did they find? When you look at the demographic characteristics, the mean age of the patients was 61.2 years with a standard deviation of 9.3, which is very similar to what you see among COVID patients in ICU in general. There were much more men compared to women. 71.5% of patients were men. The Apache 4 score was 58.9. And the number of ventilation days was 14 with an interquartile range of 8 to 22. The median ICU stay was 18.5 days with an interquartile range of 11 to 32. The hospital stay, median 32 and interquartile range of 20 to 46. When they look at the outcomes in terms of the physical, mental, and cognitive symptoms, physical symptoms were reported by 74.3% of patients, which is a fairly large number. 182 of 245 patients reported physical symptoms. Mental symptoms were reported by 26.2% of patients, which is 64 out of 244. And cognitive symptoms were reported by 16.2% of all patients. Overall, 30.6% of participants reported symptoms in at least 2 domains, and 10.5% experienced symptoms in all 3 domains at 1 year after ICU admission. When they looked at the symptoms in detail, among the physical symptoms, the most common symptom was fatigue, which occurred in 56.1% of patients. The other symptoms included frailty, general weakness, joint stiffness, joint pain, muscle weakness, persisting myalgia, and dyspnea. The majority of survivors, 57.8%, who were previously employed, reported work-related problems, and they had to go on a reduced duration of work or had to go on sick leave. Among the mental symptoms, anxiety and depression were common. Anxiety occurred in 17.9%, 44 out of 246 patients. Depression was observed in 18.3%, 45 of 246, and post-traumatic stress disorder was also identified in 9.8% of patients. Cognitive symptoms occurred in 16.2% of patients, which is 39 out of 241. So in this exploratory study, which included 11 Dutch hospitals, among patients who survived ICU for a year after treatment for COVID-19 during the second wave, there was a frequent report of physical, mental, and cognitive symptoms.
Thanks, Dr. Chacko. So I guess this study has got a significant impact on our literature because this is probably the first robust study reporting long-term outcomes of COVID patients And I guess they did a very systematic evaluation of the symptoms using the validated questionnaire. The interesting fact in the baseline data, which was very similar to what we've seen here in Australia around the duration of mechanical ventilation. So once the patient get intubated, the duration here was around 2 to 3 weeks. And similarly in this study, the median duration of ventilation was around 14 days. And also they studied a sick cohort of patients. Almost 82% of the patients in this study were mechanically ventilated. Interestingly, 1/4 of the patients had a BMI of 30, which is again similar to what we have seen. And obviously, when the patients stay in intensive care unit for almost 14 days, they almost end up in staying in hospital for a month. So that reflected quite well. And so I think the external validity of this study, even if it's a prospective cohort study, is quite good because this is a similar trend that we have seen here in Australia at least. Now, in terms of the physical, mental, and cognitive domain, this is probably the first study which reported all three different domains, and it kind of gave us a clear idea that what to expect in these patients down the lane in 1 year's time. And I guess there are previous study, especially there is a monitor IC study, which is ICU patients without COVID-19 with a similar questionnaire and cutoff values. And that study reported the prevalence rates among ICU survivors with a medical admission 1 year after the ICU treatment. So these are the ICU admissions for medical conditions. And total number of patients in this study was around 649. And in that study, out of 649, 27% patients developed physical symptoms, 35.5% developed mental symptoms, and 14% developed cognitive symptoms. So compared to that study, physical and cognitive symptoms were pretty similar. However, interestingly, with the COVID-19, the mental symptoms were actually lower compared to non-COVID patients. Now, you can argue that most of the mental symptoms recover over the period of time, and whether that is the reason why COVID-19 had lesser mental symptoms, but we don't know exact reason for that. And also, the total of 58% of the ICU survivors with COVID-19 in the present study reported problems with return to work, compared to 43% among ICU survivors without COVID-19. So, I guess the overall impact of COVID-19, even on the lifestyle and unable to return to work, is significantly higher compared to non-COVID conditions. So definitely COVID-19 has a significant impact on healthcare and the burden of the healthcare in different ways. Now, if you look at the limitations of this study, obviously this is a prospective cohort study. So this is not a randomized controlled trial. Also, the outcomes were patient reported. So they are not recorded by the investigators themselves. Having said that, the compliance with the outcome reporting was quite good. So 89% patients returned all the completed questionnaire, which is pretty good number. Also, the cognitive problems were assessed by the self-reporting, which always can be challenging, and they usually differ compared to when you do them using the neuropsychological testing. So there is that kind of difference because assessment by the psychologist is quite different than the self-reporting of cognitive symptoms. Also, the second limitation is about the information around ICU treatment, such as use of sedation, prone positioning, occurrence of delirium during the ICU stay. So that data is not captured in the study. And obviously, it would have been good to see that kind of comprehensive data, because then it would have made a good sense to compare which patients were at risk of developing these physical, mental, and cognitive symptoms, depending upon how much sedation they received, how many patients were prone and how long they were prone, and whether they developed any delirium during their ICU stay or not. So I think that kind of key information is missing from this study. And also, Dutch ICUs will be probably quite different. And also, the setting in the wards will be different, because when the patient gets discharged from ICU to ward here, we often get assessed by physiotherapists and occupational therapists, and then they go through the rehab program, because the rehab after the ICU has got significant impact on the recovery down the lane. And we don't have the data on whether any of these patients actually received the rehabilitation in the community or in the hospital. And that data is missing. That would have had a significant impact on the development of symptoms down the lane after 1 year. And the third limitation of the study is the physical symptoms are likely to be overrepresented in relation to mental and cognitive symptoms, mainly because they are self-reported outcome measures. And in this study, authors did not study the ICU patients with non-COVID-19 diagnosis. And I guess that's probably why we can't say that these symptoms are purely because of COVID-19, because sometimes what we see, especially in the second, third wave, the patients usually come with incidental diagnosis of COVID-19, but they actually got either MI or UTI or some other sort of sepsis. And obviously that probably has more impact on their long-term outcomes compared to actual COVID-19 because they're not ill secondary to respiratory illness. So I guess these are the kind of few major limitations of this study. What are your thoughts, Dr. Chacker?
I think this is a very relevant study because it followed up patients for a long period of time, or a period of a year. Although there have been several other studies which have looked at post-COVID sequelae, there have been relatively shorter follow-up. So this is probably the longest follow-up that we have seen with COVID so far. And if we look at it, the experience that we've accumulated over time, it reflects our experience as well, in that several patients have reported physical, mental, and cognitive symptoms in our practice as well. And I can offhand remember at least 3 patients who went on long-term oxygen supported home post-COVID, and many others who couldn't return to work for a long period of time. Some of them are still on sick leave at home. So the incidence of post-COVID syndrome, or the long COVID syndrome, as we call it, is reasonably high, although it may not be as high when compared to SARS and MERS, which are obviously much more severe illnesses associated with severe morbidity and mortality as well. So at the end of the day, although we don't see a proportionately large number of patients with sequelae, the sheer numbers over the past more than 2 years of COVID would surely have resulted in many patients who've been disabled to varying degrees, and they are going to seek help in the future. And that's what we would need to focus on.
Yeah, that's correct. And I guess there is one study which analyzed prevalence of mental symptoms, SARS in 2003 and then MERS in 2012. From those pandemics, there were approximately 1/3 of the ICU survivors reported mental health problems beyond 6 months after discharge, which is obviously higher than the 1-year rate of 26.2% of mental health symptoms reported in this study. So every single viral illness which requires prolonged ICU admission has significant impact on patient and their well-being for a protracted period of time. And obviously that impacts their quality of life. So at least, as you said, this study is quite relevant because it has given us a first time good data on the long-term outcomes of these patients. So as we get more data that around the long COVID syndrome, we will probably start thinking about the utilization of resources in the community, because I guess that's key is when these patients will require a robust rehab programs and early mobilization in intensive care unit or in hospital. And then also not just focusing on the physical rehabilitation, but also focusing on mental rehabilitation. That's, I think, going to be the key focus for the future. So thanks, Dr. Chacker. So that's the end of our today's podcast. We'll be back in week's time with another interesting study. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. See you next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.